So good morning, everybody. I'm really happy to be with you to start this session. The present World Leadership Dialogue combating the dual challenges of COVID-19 and health inequalities is organized by the Joint Action Health Equity Europe and Eurohealthnet with the aim to discuss the main challenges in promoting health equity in the world, also in relation to COVID-19 pandemic. Briefly, some hints on JAHEE. It is a joint action where 24 European countries jointly with the European Commission aim to make significant progress in policy response to health inequalities. JAHEE will finish in November 2022, and by that date, the recommendation based on the result of the actions being implemented by each participating country will be produced and disseminated at national level and Europe at large. Aware of how much health inequalities still represent a major challenges for policymakers around the world, we think that this event could represent an important opportunity to further highlight this issue. And thanks to our well-known speakers and to you, of course, the challenges and advances in promoting health equality will be examined, as well as the inequality implication of COVID-19. COVID-19 pandemic has further shown that health and social inequalities represent a serious challenge for countries. However, this challenge also offers the opportunity to take serious action to put health equity at the core of the recovery process in order to improve our system, making them more resilient and to avoid dramatic long-term consequences of the pandemic. As you probably know, at European Union level, all countries are working in setting up the recovery plans for the future's next 10 years. And this is a very much important opportunity to include also equity within all the plans we are going to design, to promote, and to implement. Italy, as you know, was the first European country to face COVID-19 pandemic. We have been through terrible times, and of course, we had the need to overcome this challenge, and we were successful, and this summer we had a very low number of cases. Actually, as probably you know by the media, we are facing a resurgence of the cases. Fortunately, at the moment, our resilience in healthcare system is quite good, and we are trying to control and to mitigate the effect of this wave in this day. Many measures have been taken by the Italian government to take the crisis, and really recently we produced a summary of all the measures actually in place. It is a book that you can find in our website, actually in Italian. In a few days, by Monday, will be available also in English. This is a sort of summary of what we did, but also what we are doing and what we plan to do in the future according to the different scenarios that could happen in the next weeks. 10 years ago, after the WHO Commission on Social Determinants of Health, in the light of COVID-19 developments, it is important to review what needs can be done to improve health equity in all countries, including in terms of leadership and governance for health. Just to conclude in few words, the overall objective of this meeting is to stimulate the exchange of experiences, expectations, and concerns from various regions of the world and discuss potential synergies to overcome the challenge of limiting the adverse events of this crisis and, of course, of possible future crises, and integrating health equity in national policy frameworks. Thank you very much again for participating to the meeting. I'm sure that the result of this discussion will be really useful to strengthen our network and to strengthen the opportunity to increase the awareness and the insertion of equity in the future agenda. And by my side and by the side of the institution where I'm actually the president, surely will be actively engaged in trying to do that. Have a good meeting.
Oh, sorry. Thank you very much, Professor President Busasaro. Both. Okay. So before starting, I would like to remind you to switch off the microphone and the camera when are you speaking. So now I give the floor to our experts. I am pleased to introduce the Minister of the Tigray, Dr. Lia Tedeschi. Please, the floor is yours.
Delegates and participants. I'm honored today to address this World Leadership Dialogue on combating the dual challenges of COVID-19 and health inequalities, which is an important topic that all nations must tackle during and after this COVID-19 pandemic. And I appreciate the organizers for this World Leadership Dialogue and choosing this key topic. The effort to achieve healthcare for all comes with many challenges. In Ethiopia, in the past few decades, the government has taken serious measures to address inequalities, especially to enhance availability of services to remote areas in the country and improve the quality of healthcare to the population. The pro-poor policy has improved access to agrarian, urban, and pastoralist members of society by the expansion of our community health program and our primary healthcare units. Our pastoralist communities, because they are in the remotest and most inaccessible areas of the country, they have historically been economically and socially marginalized and underserved in terms of basic social services and economic infrastructure. And cognizant of this fact, the government of Ethiopia facilitated access to crucial social services such as education, healthcare, and water supply to these underserved communities by constructing key infrastructure in remote areas, including health posts and health centers, and availing ambulance in these settings. Years of efforts of collaborative work with partners and other sectors, we have witnessed palpable impact in our community and successfully achieved 6 of the 8 Millennium Development Goals, including the health goals of reducing child mortality, combating HIV/AIDS, malaria, and other diseases. Even for the other 2 health-related lagging MDG and indicators on MDG 3 of ensuring gender equality and empowerment, and MDG 5 of reducing maternal mortality, improving maternal health, significant progress has also been observed, although the targets have not been met. In the past 5 years, we have made progress in our unfinished agendas of MDGs and revitalized efforts to achieve the sustainable development goals. So at this juncture, it's important to mention some major milestones from our latest mini DHS data that showed skilled birth attendance has increased from 28% in 2016 to 50% in 2019. Contraceptive prevalence rate increased from 35% in 2016 to 41% in 2019, which allowed to avert 2.7 million unplanned pregnancies and 600,000 unsafe abortions and 7,000 maternal deaths. Unfortunately, we still have many challenges, and now with the COVID-19 pandemic, our progress is further challenged. The direct and indirect consequences of the pandemic will remain a challenge to all. The non-pharmaceutical interventions that were in place to fight the pandemic have led to unintended socioeconomic consequences impacting also health. And furthermore, the fear of visiting healthcare facilities during COVID-19 and the balance between COVID-19 response activities and the continuity of the provision of essential healthcare services were key challenges. To mitigate some of these consequences, the government of Ethiopia took some measures to alleviate the health and social inequalities that are exacerbated and created by the pandemic. To cite few, our public health management used major communication strategy to disseminate the importance of receiving essential services during COVID, with a focus on reproductive, maternal, and child health services. At the Ministry of Health, we deployed regional support teams to the different regions to ensure continuity of essential services while responding to the COVID-19 pandemic. Our community health workers also did house-to-house surveillance and screening of over 8 million households for COVID and high-risk illnesses, expansion of COVID-19 testing sites across the regions, and intensive risk communication and community engagement using local language was done, and Ministry of Health also coordinated establishment of protection section under our emergency operating center to address people with special needs and vulnerable population. And in addition, expanded and facilitated gender-based violence shelters for survivors of GBV during the pandemic. Despite all these efforts, COVID-19 remains a setback to our progress and hindrance to our efforts, though it has also brought opportunities we need to build on. In the upcoming few months to years, it will be important to integrate and prioritize health as a local and global agenda. At this juncture, I would like to call upon the international community to join us in our efforts to address the challenge through a concerted effort that ensures a resilient health system with minimal health inequalities. Again, thank you for the opportunity and look forward to the discussions. Thank you very much.
Very much, Minister of Health of Ethiopia, Dr. Lia Tedesse. Thank you very much for your speech. And I would like to introduce the next speaker, Professor Michael Marmot, Director of the Institute of Health Equity, and also President of the JAHEE Policy Advisory Board. Please, the floor is yours. Thank you.
You are muted.
So I'm going to talk about what's been happening to inequalities in the UK, but putting it in a global context and the pandemic. A year ago, I had chaired the commission of the Pan-American Health Organization on equity and health inequalities in the Americas, and we published our report in October last year, Just Societies, Health Equity and Dignified Lives. At the beginning of the report, we quoted Nelson Mandela, "Overcoming poverty is not a gesture of charity, it's an act of justice. It's the protection of fundamental human rights, the right to dignity and a decent life." The Human Development Report of the United Nations Development Programme produced a special report recently on COVID-19, and it shows what it's been doing. Globally, here's transport injuries, HIV/AIDS deaths, self-harm, malaria, and there's COVID-19. Absolutely enormous on a global scale. As you no doubt know, the Human Development Report produces a regular Human Development Index, which combines life expectancy, education, and national income. And this is the Global Human Development Index from 1990, And you can see it was increasing every year, some years a bit slower, some a bit faster. The global financial crisis, it improved, but a bit more slowly, kept going. And the red here is what's happening, predicted to happen in 2020 as a result of the COVID-19 pandemic, a dramatic fall in the Human Development Index globally. Why am I showing you data from a hurricane? Because a hurricane is a great external threat, as is a pandemic. And the effect of Hurricane Maria in Puerto Rico saw a huge rise in excess deaths in lower socioeconomic groups, some rise in medium, and much less in higher socioeconomic groups. In other words, an external shock, like a pandemic, exposes the underlying inequalities in society and exaggerates them. There's been much, of course, and rightly, about the health care response to the pandemic. The opening lines of my book, The Health Gap, were why treat people and send them back to the conditions that made them sick. The healthcare system's important, but so are the conditions that make people sick. After the WHO Commission on Social Determinants of Health in 2008, I was invited by the British government to apply the recommendations of the Global Commission to one country, England, and I produced the so-called Marmot Review in 2010. In February this year, just before the pandemic crashed upon us, I produced Health Equity in England, the Marmot Review 10 years on. My summary of what had happened in the last 10 years is we have lost a decade, and it shows. Here's life expectancy for women and for men from 1980. It was improving at about 1 year every 4 years. And then in 2010-11, that rate of improvement ground to a halt, dramatically so. There was a new government, a Conservative-led coalition government elected in 2010. And the obvious question is it possible that the program of austerity introduced by that government was responsible for what we're seeing here? And indeed, the slowdown in the UK was greater than in most other countries. This is improvement in life expectancy, Estonia, Norway, Slovakia, Hungary, Denmark, Belgium, and there's the UK. And the only countries, rich countries, that had a slower rate of improvement were Iceland and the United States. And then the pandemic came. One way of comparing countries is not COVID-19 mortality, but excess mortality. In other words, the excess in 2020 over and above what would have been predicted from the previous 5 years. And the excess mortality in England was higher than in Scotland and higher than in any other European country. So Spain and Italy had large mortality from COVID-19, but the excess mortality in England was larger than in any other country. So to come back to what I said, the epidemic exposes the underlying inequalities in society and amplifies them. We had been managing health very badly over the last 10 years in Britain. Come the pandemic, we managed that badly too. And when we look at inequalities, here's the social gradient by level of deprivation of area of residence. The gray is all-cause mortality. You see a familiar gradient. And the blue is COVID-19 deaths, a similar gradient. In other words, the causes of inequalities in COVID-19 are very similar to the causes of health inequalities more generally, with some excess here, which is likely to be related to employment in frontline occupations and living in overcrowded households and pre-existing health conditions. When we look at ethnic differences, Black British very high mortality from COVID-19. But when adjusted for deprivation and some other factors, most of that excess can be accounted for by deprivation. In women, more than half in men. Bangladeshi and Pakistani, most of the excess is attributable to deprivation. So what happened after 2010 that led to this bad situation? A rolling back of the state. Public expenditure in 2009-10 in the UK was 42% of GDP, and that 42% went on a steady decline to 35% as a result of government policy to roll back the state. And it was done in a most regressive way. This is spending by local government per person. In the least deprived 20%, the dark grey, the reduction in spending was 16%. And then the more deprived the area, the greater the reduction. So the reduction in the most deprived 20% was 32%, steeply regressive. The greater the need, the greater the reduction in spending. And yes, that could have played a role in the increase in inequalities. Is COVID-19 the great leveler? As we know, there's real hardship for people lower down the hierarchy with the pandemic. In the US, from March to September, America's 643 billionaires increased their wealth by 29%, $845 billion, $4.7 billion a day. And the hourly wages of the bottom 82% of the workforce declined by 4.4%. The rich did very well out of the pandemic, and everybody else is doing really badly. The inequalities are being expanded. And as we come out of the pandemic, I've been quoting the New Zealand Ministry of Finance. What do we want to do in recreating society? I argue, let's follow New Zealand's lead and put well-being at the heart of what we're trying to achieve. A well-being approach which can be described as enabling people to have the capabilities they need to live lives of purpose, balance, and meaning for them. Thank you.
Thank you, Professor Marmot. Thank you very much. I remember that it's possible to ask for question by chat, please. So now I am very pleased to introduce our next speaker, Dr. Oriel Solar, Regional Coordinator on Social Determinants of Health, Pan American Health Organization. Please, the floor is yours.
Thank you very much for the invitation. An honor to stay here. The first, I would like to have a map that what happened in the region previous to the pandemic. No, Latin America is inequality is the more structural problem that we have. No, and you can see that the trends of the last 30 years, we have until 2015 some advance on reduce the poverty and extreme poverty, and also for Gini index for income inequality. No, but from the 2015, the region has increased poverty rate, in particular extreme poverty, and also we have deterioration for employment quality indicator and blood reduction for income inequality. No, in this context, that we have direct impact of what happened in health. Some of the result of them is the life expectancy that we have in the different region, in the different country in the region. And also when you analyze the difference between income, race, territory, education, that we have big inequality between of them. No, the pandemic happened in a complex economic, social, and political scenario in the region. No, there are a lot of demand and conflict, political conflict in the different country, and we have low level growth and high level the labor informality. The labor informality is some of the structure mechanisms of generate inequality, and the structure for the labor market that we have direct impact of what happened, no? Is relation for low income, is relation for without social protection, and this is one of the aspects crucial that what happened in pandemic, no? One of the group is in particular vulnerable to the loss of jobs and income during the response of pandemic, working in informal sector, mostly is women in the region and in the other region also. They often lack any type of social protection, and which exacerbate their vulnerability in case of infection, no? This structural condition or social determinant that we also talk about has an expression on health results, no, that I commented before. And what happened for the address inequality in the region? Not necessarily the region really changed some for the structural labor market or some the model for the economy. The more emphasis that you see in the different countries is the agenda for social protection, no? And you can see a lot of the focus of the reduced poverty or the group of more vulnerability condition. And you know that some of the examples that we have is the social protection in childhood, and this is comprehensive to early child development. And this is very important for some of the country implement of them. Then articulate different action policy and plan for the different sector. There are some successful examples in Brazil, for example, Cariñoso, in Chile Growth with You, in Uruguay, Chile Growth with You, also in Colombia, and also in Cuba, no? But the more common that we have in the region is the conditional cash transfer. Some of them include health conditionality, include in this. And there are 16 countries in the region that we have this program, no? And this is a program that when analyzed what happened for the inequality and the reduce the poverty, some of the program that we successful about of this is the conditional cash transfer, because it really gives support for the family and include the different integrated policies in some of them. Another is the program relation for the specific kinds transfer, no? The food, nutrition, and supplemental program. This is very important because the mechanism to distribution in the country is through the school. When close the school, this is some of the big challenges that we need to be distribution about the food for the different vulnerability population in relation for the context of the pandemic, no? Also, we have some health universalization agenda that's very strong from PAO to try to move in the region, and at the same time some social protection for maternity and paternity parental leave, no? This is some of the social protection. In this context, arrived the pandemic in the region, no? And if you see, the first is some of the data that Sir Michael presented before, no, about what happened in impact. And also, if we see the region is the really big impact that we have. Latin America countries have become the epicenter of the corona disease, no? And the region is particularly vulnerable because we have high level of labor informality that I commented before. Urbanization is one of the regions that we have a big development about of this. Poverty and inequality, and also weak health and social protection system, no? We have weak capacity that identified in the process about the public health properly, no? And this is one of the capacity to respond for pandemic. If you can see in this slide, see that the poverty level have been set back by 14 years, no? And this is really something that we have to big challenger that we have in the next 10 years about the work of this. Also, if you can see, the number of unemployment for the people in Latin America is more than 44 million that we have thinking in the 2020. And in the context of the poverty, we expect to 33%, that means 231 million the people, plus extreme poverty increase in 96 million of people, no? In this context, we analyze who is the population in the region in situation of vulnerability to give visibility the vulnerability, as you say, with social condition. And we try to analyze what happened for the group that not only thinking about the medical condition, is also thinking about what happened in relation for the social condition about of this. In this context, we talk about the burden vulnerability, and when we try to identify who's the people that we have barrier or we have some difficult to implement the preventive measurement, that no pharmacological measurement, or who is the group that we have more impact about of this. And then we try to identify the population in this condition, no? This is for us is important because sometimes when you have to majority of attention have been in the risk factor associated with the medical condition and age, but for our perspective, this vision has sometimes the risk to lose some population that very important for to address the pandemic. Some of this group is the people live in informal settlements. Some of the groups live in work in informal work, and also is some of the migrant situation that we have in the region. No, this is the three groups that we have to demand and impact in not only mortality, also we have impact that what happened with them in relation for the prevalence for the COVID in the region. No. The first that we know that this is a structural socioeconomic and political inequality pre-existent, that's something you present and comment before, no? And you know some of the group in the region that we have to beginning in the baseline in the bad condition, no? And this is impact more than another group in relation for pandemic. But additional of them, we have another layer that some of the group that really we have a difficult barrier to implement the measurement and also of them, there are not strong adherence about of this. This is something that is very difficult for some of them to not work. We got some of them in the, for example, when you are thinking in Latin America, the informal worker that we have not social protection, they are not employment insurance, and they are not income that we have to close off the space, they need to work. And then the people not necessarily follow up the different indication that we have about the public health. In this context, yes, we have some of the group that really we have a problem about of this, no? And one of them, yeah, is the people working in formal work, but at the same time, we have a very difficult problem and impact of them, two groups in the region, some of the migrants that are coming before, and also for the indigenous people, no? And also some of the impact in some of in the region is also Afro-descendant population that's very important, is close 20% of the region, no? The population in the region. Then we have additional of this, we have some of the group that really we have increased effect, adverse effect, no? And impact the measurement social distance of them. One of the examples that we have in the region is the domestic violence, no? The burden additional for the care because we close for the school and the support for the woman in some condition in house increase for the violence and also femicide that would happen in the region, no? And then we have something that we discuss in different settings about the risk mortality, about comorbidity. But for us, it's very important to identify that what happened for the different layer of the social condition that really constrain and block that really we have to move the agenda for the preventive measurement. Finally, when we think about what happened, no, what is the response of the region about of this? We are very different, no? Because depend for the content of the country, depend for the priority side. Some of them was very fast response about the measurement, preventive measurement. Another country was more focused in the hospital to respond of them. And the other we have to move forward to give some really social support about what happened, no? In this case, you can see the summary. You have the different country, and you can see the order that we have, the main intervention on policies. One of them is more close for social assistance. No, and you know, adapt the cash transfer program that exists before, extend the coverage or include additional activity. Some of the country create new transfer program to respond of this. In some of them is for the limited time, is maybe next 3 months or 6 months, another extend the time and evaluate that what happened of this. Something for the tax refund to work of this is also more for the close for the small enterprise and what happened of this. And also something about for the food program existing, no? Another create new food program, something coming before, no, in the country of the region. Additional of them, we have access to service, no? And really we have to, in some of the country, we have implement some family support to survey of psychosocial program. This is mental health is one of the big problems that we have in the region, in the different countries that what happened the COVID. The impact for mortality and the same time for the impact in relation for the measurement, preventive measurement that we implement of them, no? It also includes some housing subsidy. We have a lot of problem for the people, they lost income and we can pay the rent and lost the house, and this is the big problem also we have. And also includes some subsidies for the water, electricity, and internet. From social security, we have some unemployment insurance implemented in the region, no? Also in some of the country that you can see in the color green is more subnational level, no? Also done some adaptation for the pension system in some of the countries that we available, that we know that we have low coverage about the pension. Some employment insurance, this is not very big coverage in the region, and also the amount of them is not necessarily similar that the receipt of the money, and this is very strict problem that we have. Something that really we have to improve the health insurance, that the people really access for the tests and they're really free for them, and not on all the country this is happen. Something for sick leave, that really people to have the quarantine in relation for the contacts, and this is something also that in some of the country implement strong. And also something for the labor market, a strategy that relation for teleworking, tax reduction, and also reduce the hour of work. And you can see in some of them, and the majority, we have to address the social protection agenda, but really to try to move the health inequality in the region, no? And the diverse of them depending for the context, the capacity of the welfare state that we have in the different country, and at the same time, the political moment that each of the country is staying in this. Thank you.
Thank you very much, Mr. Solar. Ms. Solar. So I would like to ask if one of our speakers has any comment to make. Feel free to do so. Okay, so I see in the chat that there is a question for Professor Marmot. I would ask to Professor Marmot if he wants to add something else about the question.
Sorry, in the chat, there was a question about what else, apart from a well-being budget, what else could we do? And so a couple of answers. Firstly, in my Marmot 2020 review, Health Equity in England, the Marmot review 10 years on, we revisited 5 of the 6 domains of recommendations that I had made in 2010. And there's good evidence for what you could do on early child development, education, employment and working conditions, income, and healthy and sustainable communities. Are there examples of that being done? Yes, there are. Around the world, we heard a moment ago from Ariel about, for example, conditional cash transfer schemes in Latin America. Good examples of actually addressing the lack of income of the poorest women, conditional on certain behaviors. In Italy, cities such as Trieste and Bologna are taking action at the city level. In the UK, we have Marmot cities that have taken my recommendations and are applying them at city and regional level. So yeah, there is a great deal that can be done. And looking around the world, there's good examples of countries, cities, and regions already doing it.
Thank you very much, Professor Marmot. I see another question on the chat, and is for all speakers, I think. If someone wants to add something of this question, can you see on the chat? I can read for you. The question is, in the very beginning of this pandemic, the public health community already predicted that COVID-19 will eat inequalities and how. It happened anyway. Why weren't countries able to counter it?
Well, if I could start, I mean, I think when it happened, take your own country, Raffaella, take Italy. It was completely shocking. We just didn't expect it to happen. It just took everybody by surprise. I can remember listening to the BBC and thinking, my goodness, this can't be happening to a European country. And then it did. It happened to all of us. So I think the first thing was it was completely shocking. We just didn't expect it to happen. Once it was clear that it was going to happen, some of the guidelines of what we had to do became clear fairly quickly. Dr. Tedros at WHO said, test, test, test. He made it crystal clear from the beginning that widespread testing was fundamental. Most of us didn't do it. The UK didn't do it. It ditched testing in March. Italy locked down early. The UK looked across at what Italy was doing and said, oh, we're not going to do that. And then did it, but did it late. So we didn't put in place a proper test, trace, and isolate system. There wasn't appropriate recommendations early enough about social distancing. The United States, the leadership, is still not advising people to wear masks and social distance, conducting political campaigns and events without people practicing social distancing and masks. And I think, if I may, there was a false belief, and I think a genuinely false belief, that it was either the economy or public health. The evidence shows that the countries that had the biggest excess mortality had the biggest hit to the economy. The countries with the smallest excess mortality, Germany, Taiwan, Australia, New Zealand, Japan, who managed the pandemic well, had the smallest hit to their economy. The best way to avoid the hit to the economy is to manage the pandemic well. And we didn't learn the lessons quickly enough.
Thank you very much, Professor Marmot. I would like to ask to Minister of Health, Lia Tedesca, or Dr. Oriel, if they want to add something else.
Thank you. Just say a few words.
Yes.
I agree with what Professor said, that for all countries this was not, of course, expected. As Ethiopia, well, overall Africa, as we all know, it did give us some time because it started later than other countries. And there was, as a government of Ethiopia, we did take measures as quickly as possible in terms of initially before cases came in to start the strong screening on borders, but also as soon as cases started, measures were taken in terms of restricting movements and closing schools and state of emergency, although it was not a full lockdown considering the context of the country, which would have the socioeconomic impacts would really be devastating if we did that. So it was tried to balance measures for the NPI as well as some of the key socioeconomic activities to be maintained while we restrict a lot of things. So even those partial restrictions have impacted the socioeconomic conditions. So there was a multi-sectoral government approach that we try to take in terms of ensuring the protection of the social protection was in place. But this all happened in a system which was already not strong. I mean, our health system is already has its own lot of challenges, and also our overall social and economic system. So the burden was obvious, but the way that was tried to manage it in terms of maintaining the balance between the restrictions and the non-pharmaceutical interventions at community level has helped a lot. And there were key activities to protect the vulnerable population, like food banks by different cities were established by both the community and the government. It was not just the government led, but also the society, the community was also engaged in supporting the vulnerable population and addressing those in congregate settings, like in prisons, in elderly homes, to ensure that they were being tested, but also the necessary support was being given. So a combination of those activities has minimized the impact that was initially anticipated, because what we anticipated was really much worse than this. But this whole of government and whole of society approach has really helped minimize those inequalities. But even with these partial restrictions and aggressive approach of both community and government, we still had the impact of the pandemic felt at different levels.
Thank you very much. Thank you very much. Unfortunately, we don't have more time for discussion. So
can I say some small things about this? Yeah,
okay.
Very short. Okay. No, it's very short. Now, I will have to respond. For our perspective, my perspective, we have two components. One is more for the technical perspective. I think I agree with Michael that we have the shock. Nobody people believe that this is happening, some of them. But at the same time, the capacity of the health system in relation for public health is weakness. In the beginning, it's very close relation for what happened in the hospital, but not necessarily a capacity to really to test, and also not involved in the beginning the primary health care in all the process. And this is something that we discuss in the region, that's a very important point. The second point is more the political aspect. When we have some emergency, the legitimacy of the politician and the leader is very important. And sometimes in the region, we have the witness relation of the local government and the same time for the leaderships. And this is something also impact directly that what happened in the process, and this is that we need to analyze the impact of the pandemic is the technical aspect and also the political environment that what happened of this, and this is, we need to respond in both a setting, and this is for our perspective that we need to recognize,
Yes, thank you very much. So I give the floor to Caroline Costons, Director of Eurohealthnet, for the conclusion. Please, Caroline, the floor is yours.
Oh, God.
Caroline?
Yeah.
Thank you.
Yes, I had to put the system on. The time flies. There are still so many questions being asked by the participants, and we would like to hear so much more from you. Maybe to wrap up, because indeed time is going fast. I think that what we have heard from all of you is that inequalities indeed provides a root cause for many of the problems that we are facing, and is really magnifying the severity and the prevalence of the crisis that we are facing, particularly the COVID-19 crisis, but also other crises that are coming on to us, like the climate crisis, which is one that we didn't talk about much in this session, but we all know that it is impacting people. You mentioned that it is hindering progress. Michael Mahmoud said we are lost a decade, which was also noted in the figures from Latin America and also in Ethiopia. You mentioned that is hindering progress. And we know that people that are already facing deprivation and that are facing poverty, they are impacted more. They are more exposed for example, to the consequences of the climate crisis, but also exposed more to the coronavirus. And they have generally less capabilities, less opportunities, and less choices to do something about it. And we as health professionals, we have the responsibility to improve the resilience of people and to empower them and to make the voiceless heard in our research and in our advocacy and also in our leadership. And the evidence that we have seen in this session is overwhelming. We are in the midst of the COVID crisis, in the climate crisis, and crises are coming together, accumulating problems, and business as usual is not an option anymore. We need to change. We need to change our systems. We need to start meeting the Sustainable Development Goals, as was mentioned by Lia Tadese. We need to achieve like a well-being approach, which was so nicely mentioned by Michael Marmot. We've seen these approaches in New Zealand, as he said, but also in Scotland and in Finland, and hopefully increasingly in more countries. It's about a well-being economy also that works for everyone across social divides, across political spectrum. We need to use well-being indicators and see how we respect planetary boundaries. So really, systemic changes is what we need. It's easier said than done, of course, but I must say I was very inspired by Oriel from Latin America, showing how all of the social protection measures can work. Great examples in terms of labor policies, employment protection, tax reduction, health insurance, and so on. I saw in some of the comments made by participants that legislation may give the strongest impact rather than just providing advice or communication. Oriel mentioned the political aspects, the capacity of systems. So a lot was discussed in the session, and I think it reflects also the priority areas that we took in JAHEE, which is the Joint Action on Health Equity that Professor Silvia Brusaferro talked about at the start of the session, and which Raffaella Bucardini is leading, because the strengths we have in this joint action with 24 countries is to make sure that our monitoring systems for health inequalities are in place, because with the data we can make the case. Second is to design healthy living environments, including housing, which we have heard. The third point is promoting the health of migrants and ethnic minorities, and this is something that we haven't been able to touch upon in this hour, but we know that discrimination, racism are issues that are close to the heart of Michael Marmot, for example, and I'm sure all of us. A fourth element is the access to healthcare, which was mentioned by Lia Tadese, also access to quality care, in particular also in rural areas and in remote areas, because often the unmet need is higher than in urban areas, and the related social services and the social protection measures, as we've heard. And our final strand of work in JAHEE is to work on the overall governance, to have health equity as central to all of policies in government. And only in that way we can achieve a well-being approach and an economy of well-being. So I think that with JAHEE we are sort of on track in terms of the themes, which was also reflected in this session. And we really would welcome a cooperation more at the global level. As Lia said, health is an agenda for the local level and the global level, and it's often at the local level where we find solutions to address the global problems. So we would welcome really further cooperation on this, and I would encourage everyone who is listening to be in contact with Raffaella Bucardini if you want to know and learn more about JAHEE. So I think I would like to thank you from my part before I hand over to Raffaella. So I would really like to thank Raffaella and Professor Brusaferro of Italy for organizing this session in close cooperation with Vania Potati from Eurohealthnet. I would really like to express my sincere thanks to Lia Tedesa. It's really inspiring, and you do a great work in Ethiopia. I want to thank Professor Sir Michael Mahmoud also for his very inspiring talk, and I noted in the comments that many people were inspired indeed. And Dr. Oyela Sola, from your setting out all of the measures that you're taking in Latin America, and I think a lot that we can learn from. And obviously all participants that are asking questions, and I really regret that we do not have much time to talk about it all. So thanks to you, and I would like to hand over to Raffaella to then conclude. Thank you.
Yeah, thank you very much, everyone. And I would like to tell you that when it will be possible, I would like to organize here in Rome a meeting with Minister Lia Tedesa, Dr. Oriel, and of course Professor Mahmoud, together Caroline, all Eurohealthnet staff, and also with our colleagues of Jahi that I hope now is connected with us. I thank you, Professor Costa, that together with me is the coordinator of this joint action, and thank you everyone, and I hope to see you very, very often. Thank you. Bye.